Hello everyone, welcome back and good evening. Am I audible and visible? Just give me a quick nod so that we'll be good to go for today's session. Is the AV quality, voice quality all clear? Just we'll wait for a couple of seconds till the time we get a nod that yes, it is all audible and visible. Quality all clear? All right. Hi everybody. Is the AV quality good at your end? I can see at my end that yes, it is started and streaming nicely. Hi Met Psycho, good evening. How are you doing? Hi Dr. Dive. Hi Minshad, how are you? All right, Dr. Dive. Yeah, Met Psycho. There are some days in our life जिस दिन अपन बोलते हैं यार today is the worst day kind of thing, right? पनौती लग गई है. Today was one that kind of a day in my life. And no matter whatever I was doing, it was turning out to be bad or something was happening. Now, how do you take it? It's up to you. But finally, yes, we are here. There were like lots of current issues, light issues. My car broke down, then other things which were there. Everything was going haywire today. But finally, we are here. You know, things do happen. Yeah, that's it. I mean, it's part and parcel of life. But we take it in our stride, and tomorrow will be a new day again, and hopefully everything will turn out to be good for us. You know. Chalo. Yes. Shall we start, everybody? Good. All right. Thank you for that confirmation, everybody. I hope everybody is doing good. So, before we dive into any of those things, what we'll do, we'll directly start with the MCQs first, right? Rest of the things we'll discuss at the end of our session. Any doubts, any queries that you have, so that we are all aligned on the same page as to we have to solve as many number of MCQs as possible in the given time frame. All right. So I'll also give my introduction at the end for all those who are new here. The first question on your screen, which is there, right? We'll just start with the question right away. Is it visible? Yeah. A 50-year-old female brought to the emergency room, right? And she's unconscious, unresponsive. On examination, the carotid pulse is absent. What shall be the correct sequence of resuscitation? ABC, CBA, CAB, or BAC, right? That is, A stands for airway, A stands for airway, B stands for breath, and C stands for circulation, right? C stands for circulation. So what would be the correct sequence? Allied and Healthcare Solutions says C, Chandani says C, Med Psycho, Roshan, Dr. Divya, Dr. Naruto, everybody of you are telling C. Yes, guys, everybody has to answer, right? It is no doubt in your mind that you should not be answering, right? Everybody has to answer in comment section. This might be your last chance before you are actually solving the MCQs before you enter the FMGE examination. All right. Yes, Yogesh, Sophia, very good. So C stands for circulation, right? B stands for breath, and A stands for airway. So correct sequence is, first we have to start with chest compression, that is maintain the circulation, right? C stands for chest compressions. What will it take care? It will take care of circulation, right? Chest compressions, right? Then comes your A, that is airway, right? You maintain and manage the airway. How do we maintain and manage the airway, guys? This was a question which was asked twice in last 1 year, right? How do you maintain the airway? How do you manage the airway, right? The airway maneuvers are jaw thrust, chin lift, and head tilt. The question was asked on this, right? Chin lift, head tilt, and jaw thrust. All right, everybody. So this was a question which was asked twice in last 1 year, right? Not for FMG, but INICT, high chances that it can be asked for you. All right. Correct sequence is CAB. Correct sequence is CAB. All of you have given correct answer, right? Earlier it was ABC, but since 2015 we do not follow that. Since 2015, almost 8 years now. All right. Jaw thrust in traumatic unconscious situation, right? That is correct, Metpsycho. Jaw thrust, particularly in patients who have got cervical spine fractures or cervical cord injuries, right? That is where we use jaw thrust, because there you cannot do head tilt, you cannot do chin lift, right? All right. Moving on to the second question. What is the possible cause of airway compromise in a patient who is unconscious and unresponsive, right? What is the possible cause of airway compromise in patient who is unconscious and unresponsive? Lip angioedema, laryngeal edema, macroglossia, or the tongue falling backwards? Lip angioedema, laryngeal edema, macroglossia, tongue falling backwards. What is the possible cause? All of you are giving the answer as D. That is exactly correct, right? Whenever the patient is unconscious or whenever the patient becomes unconscious, what happens? Remember this, right? There is snoring, right? Or whenever there is an obese patient, what happens? They also start snoring when they fall asleep, right? And that snoring is why? Because the tongue is falling backwards. That is resulting in upper airway obstruction. Upper airway obstruction. Right? So that is resulting in upper airway obstruction, right? So that is why we should always maintain the airway. Alright, so whenever the patient convulses also, what do? You just do a head tilt for the initial part. Why? We are maintaining the airway in that patient, right? Yes, tongue is the culprit all the time. No pun intended or pun intended, right? So you should know when to speak as well, right? So tongue falling backwards is the correct answer here, right? Not macroglossia, not laryngeal edema. Lip angioedema is also not the correct answer, right? Whenever the patient is unconscious, the tongue, when it falls backward, it results in upper airway obstruction. Clear, everybody? Next question. Next question on your screen. Ventilator associated complications are all except barotrauma, subglottic stenosis, paralytic ileus, or increased cardiac output. Ventilator associated complications. Yes, Allied Health Sciences says it is C. PK says it is D. Chandani, Roshan, Metpsycho, Lakshmi, Sophia, Akshit, let it be Doc, and Lavanya. Everybody says it is C, right? What are they asking? They are asking the exception rule, right? So which category does it fall into? Our girlfriend googly question. Remember, it is an exception, right? So whenever the patient is on ventilator, what happens? There is an external force which is giving, mechanical force which is giving the breath, and the patient is passively expiring, right? So active inspiration of breath is not there, right? So whenever we inspire, what happens? The inspiratory or the intrathoracic pressure is increased, right? So whenever there is increase in intrathoracic pressure, what will happen? Yes, whenever there is increase in intrathoracic pressure, what will happen? The blood flow to the thorax from the upper and lower part of the body will increase or decrease, right? Whenever the intrathoracic pressure increases, So what will happen? The blood flow to the thorax will increase or decrease because the pressure here is increasing. So it is giving less area, less size. It is squeezing the vessels. So the blood coming back to the heart will decrease, right? Exactly correct. Yes, Pankaj, yes, Akshit. So the blood coming back to the heart will decrease. So what will happen to the cardiac output? Cardiac output will increase or decrease? Cardiac output will decrease. All right. So this is one point that you should remember. Second, whether barotrauma. Trauma means injury trauma. Baro means pressure. So pressure related trauma can happen because of ventilator. Yes. So this is a complication, right? Subglottic stenosis. This is the glottic where your vocal cords are present, right? Subglottic. Sub means below the glottis. Sub means below, right? Subway, right? We say na subway khane wala, subway jane wala, right? Below that. So subway means, sub means below, right? Subtraction, minus, right? So whenever subglottic, that means below the glottis, is there stenosis? Yes, it can happen. Why? Because of prolonged intubation. Endotracheal tube, prolonged intubation, right? So why there is prolonged intubation? Because the patient is on ventilator, right? So subglottic stenosis is a correct answer. Paralytic ileus, most of us are confused here, right? So whenever the patient is on ventilator, does the patient eat? What do? We give Ryle's feeding to the patient, right? We give Ryle's feeding to the patient. Ryle's tube is inserted, correct? So whenever there is Ryle's tube which is inserted, we give liquid diet. And when the patient is not mobilizing, the patient will always go into constipation. Sometimes there will be paralytic ileus as well, because the mobility and the motility of the intestine is compromised, it is decreased, right? So paralytic ileus, yes, it is a complication of your ventilator. Why? Because the patient is not eating and not mobilizing. Clear, everybody? Right? And why there is decreased cardiac output? We have just said the mechanism for the same as well. All right, wonderful. Next question. Which layer is not pierced during the following procedure? Ligamentum flavum, arachnoid matter, supraspinous ligament, or skin? Which layer is not pierced here? Lakshmi, Naruto, everybody is telling that it is arachnoid matter. So tell me the name of the procedure that is being conducted here. Yes, what is the procedure that is being conducted here, guys? Which needle is this? The procedure being conducted here is epidural anesthesia, right? Lumbar puncture nahi, epidural. Look at the needle, right? Are you able to see these serrations and markings, right? Plus there is this needle hub ke baaju mein there is this stabilizer as well which is present, right? It is an epidural, right? So this is an epidural procedure which is being conducted here. All right. Yes, so this is the needle which is there. The name of the needle is Tooheys needle or Towey's needle, right? Tooheys needle, right? So needle is Towey's needle. Procedure being conducted is epidural, right? So what are the layers which are pierced when we do lumbar puncture or when we do epidural, right? So first and foremost is it starts from skin, right? Then comes your subcutaneous tissues, right? Then comes your ligaments, that is supraspinous ligament. After that, interspinous ligament, right? Supraspinous and interspinous. Then comes very important ligament, that is ligamentum flavum, right? Very important ligament. After this comes your dura mater, right? Then comes your arachnoid matter, DAP or PED, inside outwards, right? And then comes your pia mater, and then it is your spinal cord. So what is the procedure? It is epidural. Epi means sub, means below, epi means above, right? So above the dura, the space which is there, that is known as epidural space, right? That is known as epidural space. And ligamentum flavum is the toughest of all ligament. Ligamentum flavum is toughest of all the ligaments, right? So whenever you cross the ligamentum flavum, what do you get? You get loss of resistance. You get loss of resistance, because as soon as you cross the toughest layer of ligament, you get loss of resistance. So there is this loss of resistance technique. This is your epidural space, and here is where you stop, right? But when we are giving spinal, we cross the arachnoid membrane. Spinal is also known as subarachnoid block, right? It is also known as sub means below, subarachnoid block. So this is the area for this, right? So this is the place where you will encounter cerebrospinal fluid, that is CSF. Clear everybody? Samjha sabko, right? So the layer which is not pierced is arachnoid matter, right? Skin is pierced, supraspinous, interspinous ligament is pierced. Ligamentum flavum is the last ligament to be pierced. Clear? Next question. Identify the position which is shown in the figure. Identify the position. Identify the position. Is it Trendelenburg, reverse Trendelenburg, lithotomy, or lateral decubitus, right? Everybody of you, Lavanya, Chandani, Metpsycho, Dr. Naruto, PK, Abhishek, Akshat, Dr. Nisi, very well done, very well done. Yes? Lower abdomen or upper abdomen surgery, right? When do we do this reverse Trendelenburg surgery or reverse Trendelenburg position? Lakshmi, very good. Vashishta, yes. Chandani, Femida, yes. Rohit, let it be dog. Wonderful, guys, wonderful, right? So Trendelenburg means when there is head low position, right? Trendelenburg mein head is at the lower end. Reverse Trendelenburg is exactly opposite of that. That means the head is above the foot end, right? One is your supine position. When the head goes up, it is reverse Trendelenburg. When the head goes down, it is Trendelenburg. So how do we remember these? These are the positions that you should know, right? So one is supine position, right? Second is prone. Prone means you are lying on your tummy. You are lying down on your belly, right? Then comes your lithotomy position, Fowler's, or you can also call it like sitting position or beach chair position, right? Then is your jackknife position or knee chest position. These are usually done in your rectal surgeries, right? Lithotomy is also used for your perineal surgeries, right? Lateral position or kidney position, more or less similar, just with a wedge for the kidney. What comes here is, this is your Trendelenburg and this is your reverse Trendelenburg, right? Look at the T the way I am writing, that's it. Alright. With Fowler's, yes, Chandni, exactly. Sitting position, anytime sitting position, there is high chances of venous air embolism, right? Venous air embolism, high chances. Alright, clear? For LSCS Pankaj Mishra, we will go with supine position, right? For LSCS, we go with supine position. Okay, got it? Jackknife position, most of the times nowadays not used, right? This jackknife position, even the knee chest position, very rare surgeries are there in which we use them, otherwise not used nowadays. Exactly. Alright. Next question. fastest acting non-depolarizing muscle relaxant. Fastest acting non-depolarizing muscle relaxant. Succinylcholine, mivacurium, rocuronium or atracurium. Which of the following is fastest acting? Think and answer, guys. Think and answer. Right? Some people are telling it is option B. Some are telling that it is option C. Some are saying that it is option A. Right? Now, chalo, if I'll just change this and write it as shortest acting. Shortest acting. Yes, if I'll just change the wordings, what would be your answer? I'll just give you 10 seconds, okay? 10 seconds more. A, B or C, right? I'm getting all different types of answers. Okay. Now what I'll do, I'll go back to the previous question and I'll just take off this thing. Fastest acting muscle relaxant, right? Now I'm asking fastest acting muscle relaxant. That's it. Just a generalized question. What would be your answers now? And now instead of fastest, if I again come back to the question as shortest acting muscle relaxant, right? So when a generalized question is asked, that is shortest and fastest acting muscle relaxant, your answer can be succinylcholine. Why? What is the onset of succinylcholine? 30 to 60 seconds, right? What is the onset time for succinylcholine? It is 30 to 60 seconds, right? Whereas the duration of action for succinylcholine is 5 to 15 minutes, right? 5 to 15 minutes. Whereas what was the first question? It was non-depolarizing muscle relaxants, NDMR, right? So which is the fastest acting non-depolarizing muscle relaxant among the following? It is rocuronium. Why? What is the onset for rocuronium? It is around 90 seconds, right? Whereas the onset for atracurium and mivacurium, it is around 3 minutes, right? Around 180 seconds, correct? But what about the duration of action? Duration of action of non-depolarizing muscle relaxants here, mivacurium is the shortest of all, right? So what is the duration of action? It is less than 20 minutes, right? Whereas roc and atracurium are intermediate acting. The duration of action is 20 to 40 minutes. 20 to 40 minutes. Clear? So when the question is being asked regarding muscle relaxants, always be sure, right? How do you classify muscle relaxant? One is depolarizing and the other group is non-depolarizing. Right? Depolarizing, there is only one option, that is succinylcholine. Rest all the drugs fall into non-depolarizing muscle relaxants. Now clear? Alright? Samjha ye question, understood this question, basic question, but this is how the examiner will try and play with you and you will be committing silly mistakes here, right? So read the question, be there and have the presence of mind, right? But what happens? Because we have not solved such questions previously, when such questions come in the exam, we tend to perform silly mistakes, right? So that should not be the case with us, alright? Atracurium is used in pregnancy, pediatric old age. Yes. Atracurium nowadays is the most widely used non-depolarizing muscle relaxant. Why? Because of its very specific property of Hoffman's elimination, and ester hydrolysis, right? So pediatric, pregnancy, old age, even in young age, everywhere we try and use atracurium as much as possible. Alright, next question. Identify the equipment that is shown. NIV, high flow nasal cannula, or oxygen concentrator. What is this? Yes, Chandani, very good. Yes, Dr. Setu. Mohan Raj, well done. PK, yes. Everybody of you, Dr. Naruto, yes, exactly correct. Well done, guys. Lavanya, good going, guys. So try and assess simultaneously along with the answers that you are giving, right? Pranav Kade, very good. Yes, Shivani. So what is this? This is a high flow nasal cannula. High flow nasal cannula. Yes, this is the flow meter. What is the rate at which you can give? High flow means almost 60 to 70 liters per minute. That is that high the flow of oxygen can be given through this, right? Since it is a dry gas, you require a humidifier, and this is the nasal cannula, right? So this is humidifier, this is your flow meter, and this is your nasal cannula through which the oxygen is being given to the patient, right? So just before induction, that means just before intubating a patient, you can avoid that intubation by instituting high flow nasal cannula in ARDS patients, right? This is how we saved many patients from going into ventilator or going on to ventilator by giving a high flow nasal cannula during the COVID period, right? So this is that equipment. All right. Maximum FiO2 delivery is by FiO2, that is fraction of inspired oxygen concentration, is by Hudson mask, NRBM, nasal cannula, or Venturi mask. Maximum FiO2 delivery is by option A, option B, right? Hudson mask, NRBM, nasal cannula, or Venturi mask. All right. So how does this different oxygen delivery devices looks like? This is the picture, right? Normal room air, what is the concentration of oxygen that we are breathing, guys? FiO2 that we are breathing at normal room air, around 20 to 21% oxygen is present in air, right? So what we are breathing right now, the FiO2, if I say, is around 21%, right? 20 to 21%, right? So but when the oxygen requirement of the patient increases, or when we want to deliver external oxygen to the patient, right? So these are the various devices through which we deliver, right? So first is your nasal cannula. Nasal cannula, you can get a FiO2 of 25 to 40. Second is your Hudson face mask or face mask, right? FiO2 is in the range of 40 to maximum 60, right? The third option was NRBM, that is non-rebreathing face mask or bag mask, right? So here you attach reservoir bag to the Hudson mask, right? It is a extension of that. So through this reservoir, you can increase the FiO2 through that by 80 to 95% of oxygen can be given, right? Maximum is 100, that can be given by high flow nasal cannula that we have just seen, right? Up to 100% of FiO2 can be given. So correct answer for this question is NRBM. Around 95% at high flow can be given to that. Clear? Right? So these are the various oxygen delivery devices that you should know of. Tell me the size of this IV cannula. This green colored IV cannula. Tell me the size of this. 16, 18, 20, 22. Shall we increase it more? 14, 24, 26, right? Tell me the size of the IV cannula that is shown in this figure. Exactly correct, guys, exactly correct. Now tell me the size of this IV cannula. Yellow color, right? What is the size of this IV cannula? Yellow color. Yellow color, yellow. Exactly correct. Yes. Mohan Raj, Lavanya, Naruto, Chandani, very good. So yellow is 24. Now tell me what is the size of this IV cannula? Blue color, right? What is the size of blue color of IV cannula here? Yes. What is it? Blue has gone off. Okay. Now it is there, visible again. What is the size of this IV cannula? Blue color. Exactly correct, guys. It is 22. Tell me the size of this IV cannula now. Purple color. Purple color of IV cannula. What is the size? Purple color. Yes. What is the size of purple color of IV cannula? Exactly correct. Yes. So next is your pink color. Pink color IV cannula. What is the size of pink color of IV cannula? Right? So all the IV cannulas is what you have remembered, and everybody of you have given correct answers, right? Yes, it is 20. So how do we remember? With the help of this figure, right? Lava, that is orange, so it is 14, lowermost, right? Then comes your soil, which is gray in color, 16. Then comes your garden or plants, green in color, 18. Then there is a beautiful pink color flower on top of that, so it is 20, right? Then above that is the beautiful sky, blue color, 22, right? In the sky there is bright shining sun, 24, yellow color ka sun, right? And beyond the sun, when you go, there are galaxies, stars, right? Milky Way, violet or purple in color. Clear? Yes. Next thing that you can be asked is the flow rates, right? So start with the top, that is 14 and 24, right? Maximum is around 250 and lowest is around 20, right? If you go with 26, it is around, maximum is 10 ml per minute, right? So 10 ml per minute is the maximum that you can give with 26, right? So 24 and 26 are used in infants, right? So up to 20 and 22 they are usually used in children. 20 is usually used in adults, right? But 16, 18 and 14 gauge are usually used in adults for rapid IV infusion. For rapid IV infusion, right? Look at the rates. You can go up to 250 ml per minute, right? In 4 minutes you can infuse almost 1 liter of fluid, 1 liter of saline, right? So that is why for trauma, IV resuscitation, hypovolemia, we use 18, 16 and 24, 14 gauge cannula, right? Even in surgeries where we are expecting a lot of blood loss, we go with 16 and 14 gauge cannula. Alright? So this is the thing, this is the image that you should remember, right? And whenever such question comes in the exam, take a minute, write down and then answer. Alright? Moving on to the next question. A patient of COVID-19 requires oxygen. Which of the following cylinder is used? Brown, blue body with white shoulder, black body with white shoulder, or blue color? Right? Patient of COVID-19 requires oxygen. Which of the following cylinder is used? Excellent, guys, excellent. Everybody of you have given correct answer. Suppose the same patient, if the patient requires nitrous oxide N2O, what is the color of cylinder that will use? The options are brown, blue body with white shoulder, black body with white shoulder, or blue color? Yes, what will we use? Lavanya, very good. She has also mentioned the pin index of oxygen. Very good, Chani. Entonox. Exactly correct. So, nitrous oxide is blue. Entonox, you have mentioned it correctly. Alright. Next one. Blue pipeline in OT is for which anesthetic gas? Blue pipeline in OT is for which anesthetic gas? Options are air, oxygen, nitrous oxide, or vacuum. Excellent, guys. So this is same, right? So let us have a look at all the pipelines. Right, last year onwards they have started asking question on pipeline now, right? Till now cylinder was being asked, but now they have started asking about pipelines. So be sure whenever you are answering such questions you should be prepared for that, right? So blue color we have just now asked. Blue color is for nitrous oxide. What about yellow, guys? What about yellow? Yellow color pipeline is for what? Yellow colored pipeline is for what? It is vacuum, right? It is vacuum. What about white color? Very good, mid psycho. So what about white color? Yes, Lavanya. It is oxygen. White night, right? It is oxygen. So what is left out? Black color pipeline. It is carrying air, right? It is carrying air, right? So whenever you enter the OT or whenever you are there in the hospital, and if you look around and there are pipes running throughout, so you should be able to tell which pipe is carrying what. Alright, exactly correct. Next question. All are the benefits of supraglottic airway device over endotracheal tube, except it requires less time for insertion, less hemodynamic changes are there, it prevents aspiration, or it is less invasive. What is the benefit of using supraglottic airway device over endotracheal tube? And what is it telling? It is asking exception, right? This is what it is asking, exception. Everybody has given correct answer, yes. So does it require less time for insertion? Yes, you just open the mouth, glide it in, that's it, right? But for laryngoscopy you require little expertise, you require positioning, right? For putting in the endotracheal tube you need to perform direct laryngoscopy for that, right? So this is a true statement, right? Less hemodynamic changes, since no laryngoscopy, so no hemodynamic changes, so no rise in blood pressure. So this is again a true statement, right? Prevents aspiration? No. Why? Because it is supraglottic airway device, right? Airway goes and stucks in the upper airway, that is supraglottic region, right? So whenever any device crosses the glottis and goes into trachea, those are definitive airway device. And if they have cuff, they will prevent aspiration, but not LMAs or any supraglottic airway device, right? So this is a false statement and exception was asked, right? It is less invasive, yes, because it is lying in the supraglottic device, right? In infra, yes, infra means below the glottis, right? Those are known as definitive airway device, right, med psycho? So definitive airway device means which are going and settling in the trachea, right? So those are definitive airway device, and if they have cuff, so they will prevent aspiration. What prevents aspiration? The cuff of the endotracheal tube. That is what prevents aspiration. All right. Next question. So this is how it looks like, right? So this is your endotracheal tube with cuff, and this is your LMA with supraglottic airway device, which we call it. Identify the following in white, right? Identify the following in white. SpO2, EtCO2, MAC or IABP, this one white, right? This was again a question which was asked in recently concluded INI-CT exam. All these are very, very, very important questions, right? Exactly, all of you have given correct answer. This is capnography, that is EtCO2, end tidal carbon dioxide. Everybody of you have given correct answers. Move on to some of the questions on capnography, sequential arrangement regarding the same, right? How and what are the phases that are being shown here? Phase 1, phase 2, phase 3 and phase 4. Arrange those, right? And if you understand these phases, you will be able to understand capnography very easily. Phase 1 stands for what? Alveolar ventilation, dead space ventilation, inspiratory phase or alveolar per dead space ventilation, right? Arrange them. Phase 1, phase 2, phase 3 and phase 0 or phase 4, right? So we have already started to get some answers. That is B, dead space ventilation, then A, that is alveolar ventilation, D, that is alveolar plus dead space ventilation. Chani says it is option A, that is alveolar plus dead space is first, right? So how is this EtCO2 produced? Let us go into that first, right? So that you will understand it forever now. Yes. This is your lung. Right, this is your lung, right? So what is going inside? Air or oxygen is going inside, right? From here it goes to the alveoli. From the alveoli it is carried by the blood vessels, right? By the blood vessels, where it is carried to the target organ that we call it as cells, right? What happens to in the cells? Oxygen is taken in, what is given out? Metabolism happens and CO2 is given out, right? So this CO2 is being carried from the cells via the blood vessels again back to the alveoli, and then CO2 is exhaled out, right? So this end tidal carbon dioxide is what we are taking care of right now, right? So what is the first gas when we expire, right? Suppose we are inspiring, what is the airway? Nose, nasopharynx, laryngopharynx, larynx, trachea, then comes your principal bronchus, and then so on and so forth till the alveoli, right? And when I expire, which is the first gas to come out? It is coming out from my nose, the first gas, right? So which was the last gas which went in? Air or oxygen that went in. So what is the first gas coming out? It is nose, right? From the nose. From after nose, then comes your nasopharynx, laryngopharynx, then trachea, right? In all these places, if I've inspired oxygen, what is coming out first? Oxygen is coming out, right? So is there any gaseous exchange taking place here? No. So what are these spaces called? These are known as dead space, right? It can be anatomical or physiological. So first is your dead space ventilation, right? Clear? Now there is a mixture from the alveoli and the trachea and the principal bronchus gas which is coming out now, right? So slowly the carbon dioxide value or the carbon dioxide concentration is starting to go up, right? So first it is 0, that is phase 0 is dead space ventilation, no carbon dioxide, right? Then you will see that the CO2 value is rising. So it is dead space plus alveolar gas. Alveolar mein there was carbon dioxide, right? Remember, right? Then comes a phase, that is phase 3, where the carbon dioxide is plateaued. That means only carbon dioxide is present, right? So that is your alveolar gas which is there, right? So it is alveolar ventilation. Only the carbon dioxide is present now in that circuit, right? Then you can see that the carbon dioxide value is falling down back to 0. So phase 4 is what? It is phase of inspiration, right? So again it is coming back to 0, that is it is phase of inspiration. So what is the correct space? First is dead space ventilation. Second is alveolar plus dead space ventilation. Third is only alveolar ventilation and inspiratory phase is last, that is phase 4. So what is the correct sequence? B, D, A and C. Correct answer is option C. Understood guys? Yes. So if you have understood this, you will be forever able to answer the question, right? Also you should know what requires for the carbon dioxide value to be normal, right? First thing, ventilation of the patient should be proper, right? If the ventilation is proper, inspiration expiration is proper, carbon dioxide can be proper, right? It can be normal. If circulation is proper, only then the carbon dioxide will be carried from the cells to the alveoli, right? And oxygen from the alveoli to the cells, right? And if metabolism is proper, only then the carbon dioxide value will be normal and proper, right? So EtCO2 tells you about ventilation, it tells you about circulation, and it tells you about metabolism. So there are 3 factors that you have to understand whenever you are reading or discussing about the EtCO2, right? When we discuss about this graph, what are we discussing? We are actually understanding the underlying cardiac cycle, right? Or cardiac circulation, right? This is P, Q, R, S, T, right? So this is a graphical representation of what is happening in the heart, right? So this is the graphical representation of what is happening in the ventilation, in the circulation, and in the metabolism whenever the patient is under anesthesia or whenever you have connected EtCO2. Got it? Got it? Yes. Therefore, EtCO2 is a very important monitor when it comes to anesthesia. It will tell you about 3 things. One is ventilation, second is circulation, and third is your metabolism. Clear everybody? Yes. Any doubts so far? ठीक है, shall we move on to the next question? Identify the following graph. Identify the following graph. Is it a graph showing bronchial asthma, endobronchial intubation, spontaneous efforts, or it is a graph showing cardiac arrest? What is this graph conveying? There is normal capnograph and there is absence of capnograph, right? Just now we have said the 3 things which will help us in getting normal capnograph: ventilation, circulation, and metabolism, right? So if any of these things is not working or is absent, you will not get a capnograph, right? So there are 2 normal capnograph followed by sudden loss, that we call it, right? So it is sudden loss of capnograph or sudden loss of EtCO2, right? So what are the 3 things? 1, ventilation, second, circulation, and third, metabolism. So what is happening here? Circulation is not happening, that means cardiac arrest, right? Or the other can be ventilation is not happening, right? It can be either tube dislodgement, right? Or it can be accidental extubation because it is sudden, right? Because it is sudden, that means you were able to ventilate and suddenly the patient is not being ventilated. So it is accidental extubation. Or it can be circuit disconnection, right? These can be the ventilatory parameters because of which it can happen. For esophageal intubation, Lavanya, you will not get a graph only, right? Or you will get a graph something like this. You will get something like this, right? Just one upstroke and then you will get a zero graph, right? But here what was happening, there was normal capnograph followed by sudden absence, whereas in esophageal intubation you will not get a graph. Yes, Metroid. Bronchial asthma, endobronchial intubation, spontaneous efforts, let us have a look into that as well, right? Chalo. There are more graphs coming up your way. Okay, Dr. Metroid. A 60-year-old female patient with heart rate of 72, blood pressure of 180 by 94, SpO2 of 100%. EtCO2 of 45 millimeters of mercury was present. Suddenly, the nurse notices the following capnograph tracing after the patient is shifted to the MRI for imaging studies, right? What is the cause, right? When you intubated the patient in the ER, you were getting all the parameters normal. But as soon as from the ER, the patient is gone into the MR suite, what will happen for MRI? Sudden loss of capnograph. So what is happening here? Yes, exactly correct. While transferring the patient, there can be a pull on the endotracheal tube and it has been dislodged. It is out of the trachea. Therefore, you are not getting ventilation, right? So there are normal capnograph followed by absence, right? Let us discuss other graphs as well so that it is clear in your mind. A patient is being operated for laparotomy. The patient is intubated with succinyl choline. Intra-op, the patient develops fever, hemodynamic instability with following capnograph. What is the treatment? You will see that there is increase, and that too massive increase in EtCO2, right? Massive increase in EtCO2. When you will find high EtCO2, high carbon dioxide production, when will it be there? Remember the metabolism part, cells where the metabolism is happening, where the CO2 is being produced, है ना? Just now we have discussed this, right? At the cellular part, when there is increase in metabolism, so which will lead to increase in carbon dioxide production, right? So increase in carbon dioxide production is actually telling you what? It is increase in metabolism. Which condition will have increase in metabolism? Malignant hyperthermia, right? So what is the treatment of that? Dantrolene. Exactly correct, guys, exactly correct. See, now you are understanding this, है ना? Next question on your screen. Following intubation with atracurium, following capnograph is seen. What is the reason? COPD, bronchial asthma, bronchospasm, or all of the above? What kind of a graph is this? Right, exactly correct, guys. So what will be the answer for that? What is this? Shark fin appearance, right? Shark fin appearance, है ना? So where do we see such kind of graph? What is happening here? The phase 3 of capnograph, that means the alveolar phase emptying is taking longer time, right? Phase 3 was what? Alveoli. So it is taking longer time from the alveoli to empty. So that means there is upper airway obstruction, right? So shark fin appearance is seen in upper airway obstruction. So which are the conditions which will cause upper airway obstruction? Bronchospasm. Yes. In bronchial asthma, do we get airway obstructions? Yes. COPD is nothing but a type of asthma which has been prolonged and you will get spasm. So again, what is happening, guys, here? Yes. So what is happening here? Yes. So cola note, everything is coming up. Yes. So it is all of the above. It is all of the above. That is the correct answer here. All right. So in COPD, bronchial asthma, bronchospasm, you will get such kind of graph that is known as sharp fin appearance. All right. Next one. The following capnographs suggest rebreathing, spontaneous efforts, pulmonary embolism, or malignant hypothermia. What is it? Yes. You are seeing that in phase 3 of capnograph, right? In phase 3 of capnograph, there is a sudden cleft which is developing. So this is an inspiration or a short inspiratory effort, right? So this is known as cleft. What cleft? Curare cleft. Curare was the first muscle relaxant which was used. So this is curare cleft, right? Therefore we call it curare cleft. That means the patient is coming out of your muscle relaxant. Alright. Patient is starting to take some spontaneous efforts, spontaneous breath. So correct answer for this question is option B, spontaneous efforts, right? 2020 question, right? NEET PG. Can be asked, right? So I hope you guys enjoyed. We have done a lot of questions today, right? But before we wind up, just a few announcements for all of you, right? What we have come up with is the bigger savings unlocked on Unacademy, right? You are getting now 25% off, and this is valid for next 3 days, right? Including today. So it is valid till 30th of June. So if you are planning to buy Unacademy, this is the best time for all of you, right? 25% off comes very rarely, right? So what is there on Unacademy guides right now? All of you know about NEET PG Vitals. What are Vitals? Vitals are nothing but these are our recorded videos. So everything is compiled to one place where you will be able to see everything. Plus apna special classes going on, where MCQ marathon live such discussions are going on. You are able to answer in quiz based session where you will get the leaderboard. Plus the 2 batches that we have launched is for your next or NEET PG 2024, but now next has already been announced, right? So make sure that you are getting access to this batch, and now it's like hardly 6,000 bucks, and along with that you are getting the vitals, that is recorded session free, right? And FMGE, the final frontier which is there, right? Last 1 month ka batch which is there, you will have 100 plus hours of content, live classes going on. Plus there is one very important aspect with this live class. What is happening? Live MCQ discussion, right? That is the best part about it. So all the T&Ds will be happening here. Alright. And all those who are new here and who don't know me, I am Dr. Hitesh Nathani, your mentor, your educator, your friend for the subject of anesthesia on this wonderful platform of Unacademy, right? So thank you Med Psycho, thank you Akshit, thank you Chandani, Dr. Naruto, Lavanya, Dr. Nisi. I hope you guys enjoyed today's session, right? If you have any doubts, I am still available. You can just ask me any questions. And remember guys, the secret for your future and the success is hidden in your daily routine, right? What do you do now? What do you do in the day is what is going to define what you become in life, right? If you are wasting today, you're going to waste your life. If you are utilizing your today, doing all the productive work, you are going to have a very productive life, right? So make sure every day is counted from here on till 30th of July, right? Do not waste a single day. Do not waste a single day. And if you're wasted, no issues. Don't be in that guilt, right? Tomorrow is going to be a new day again, right? As I have mentioned in the start of the lecture, tomorrow will be a new day, right? All right. Thank you all for joining in. Yes, a very productive session. Thank you, Iman. Thank you, Met Psycho. Yes, thank you, Travel with Chandan. So I hope you guys enjoyed today's session. I did enjoyed this a lot by your interactions and with your answers, right? So after this, what happens, guys? You should understand the topic that you are weak in, and you should be able to answer that, right? So make sure the topics that you are weak in, you should be able to answer those and repeat those topics, solve more MCQs of those topics, right? Okay. So this is the big announcement and the big discount which is going on right now, 25% off on our plan of all Unacademy subscriptions, right? So whether you want to take the next batch or for FMG batch, you will be getting 25% off. All right. So till the time we meet again, guys, this is your host, your mentor, your educator, your friend for the subject of anesthesia on this wonderful platform of Unacademy. Make sure you subscribe and like and also hit the bell icon of this channel so that you will get notifications whenever there are such classes coming up, right, your way. So until we meet again, bye bye, take care, stay blessed, stay disciplined, stay motivated. I'll see you in our next class. Till then,